Good afternoon, everybody. And it is as I say, this is our Pan India ILD MDM Friday today, and we are again here with three more complex cases. And today we are fortunate to have once again Professor Ethel Wells, who is a consultant respiratory physician in Royal Brompton Hospital, UK. Welcome to you, sir, to our program. Thank you so much for joining. And we have our usual experts, Sujit Rajan, Bhavin sir, and Talwar sir. Along with that, we have got Harjit Singh Dumra, who has one case, but other cases he can be very well expert also. Welcome, Harjit Singh, and all my experts who are always so kind to join. And we have got Dr. Vimal Raj here today, and that is also really pleasure to have you, sir. And Bhavin sir with Vimal Raj, it will be a great combination today. So without further ado, the plan is we will discuss one case. I will be sharing slides and Rushi will be presenting. So I'll just start my screen. Slideshow from beginning. So my slides are visible and it is moving, right?
Yeah.
Yeah, okay. Go ahead, Rushi. All
Yeah.
yours.
So good evening, all of you. So I'll start the case directly. So it is a 60-year-old man, butcher by occupation. He had a history of chicken exposure also. He is a chronic smoker, smoking since last 35 years and stopped 5 years ago with 10 cigarettes plus 25 BDs per day. He is also tobacco chewer and some history of atopy that allergic to dust is present. In a comorbidity, he have type 2 diabetes since like 6 years, managing with the OHA. Complaints when he came to first visit to OPD in December 2022, that is dry cough since 1 year and worsening dyspnea since last 6 months. The past events and hospitalization from patient side, he had a history of URTI in year 2021. After that, three admission are there. One is acute exacerbation ILD in Feb 2023, then June 2023, and current admission is again acute exacerbation of ILD April 2024. So I'll just go through with the patient ODP. In December 2022, when he came to OPD with the dry cough and breathing difficulty, his room air saturation was 88%. He have already PFT done, which was FEV1 was around 91% with the normal spirometry, and echo was concentric LVH with RVSP of 35. We had done the CT scan, but that CT scan is not available. But report suggestive of emphysematous changes with basal fibrosis. So we thought about could be a CPFE because of chronic smoking history was there. We started on short course of corticosteroid and antifibrotic pirfenidone, and we had discussed with bystander regarding need of cryobiopsy versus risk and complication. So at that time, patient was not agreed, but within 1 month we had able to do the cryobiopsy. So in Feb 2023, after 2 months with the cryobiopsy follow-up, in cryobiopsy it was suggestive of chronic hypersensitive pneumonitis. So we had started on corticosteroid and MMF, and antifibrotics was stopped. But we had repeated 2D echo on that OPD visit. RVSP has jumped to 76 and dilated RARB, diagnosed as interstitial lung disease CHP with the severe pulmonary hypertension. And we had done try to follow up with 3 months in May 2023. Again, we had repeated PFT on May 2023, which was normal. I'm showing the data on next slide, but saturation was again 87% on room air. So it was not matching with the PFT and SPO saturation. So we had counseled them about right heart catheter, but they are not willing. So we started on tablet tadalafil, and to see the response, we had told to follow up on 2 months. But they came fall into next month in June with worsening breathing difficulty, and saturation dropped down to 78%. 2D echo we had again repeated. RVS we had dropped down to 52. EF was 60%, and the normal all wall chamber. We had withdrawn the tablet tadalafil, but steroid we had increased because of the worsening breathing difficulty. That was looking like exacerbation, and after 5 days of OPD visit, he fall into the emergency with the complaint of fever, bilateral edema, and the breathing difficulty. At that time, saturation was 70%. We thought to go for the CTPA. We had done the CTPA to rule out the any other causes of the hypoxia, and There is the dilated main pulmonary right and left pulmonary, and same changes of emphysema with the fibrosis was there. We are treated with the steroids and other supportive and follow up in the after 1 month in July. July patient improved because of we had given steroids at that time and room air saturation was 92%. We had restarted tablet nintedanib, MMF continued and steroid tapered. On September 2023, he again came to OPD. Room air saturation was at 84%. Advice for LTOT, and we had also counsel about lung transplant. But patient we lost the follow up to 6 months. Next slide, ma'am.
Yeah,
Last follow up.
Rushi, sorry to interrupt you. I don't think you have to read everything because we will be running short of time. So just say the relevant things which is important.
Okay. So now in present admission, after 6 months, patient came to ER with the breathing difficulty. We had done the CT thorax and abdomen. CT thorax was same suggestive
Yeah,
of emphysematous
yeah,
change.
just leave there. CT scan we will show that
And
time, sir will show.
and we had follow up 2D echo also. Again, RVSP of 60 with the good LV systolic function and PH. Previous our issue was disproportionate hypoxia because PFT was okay and respiratory failure because patient is on room with the LTOT of 5 to 6 liter with the 90% of the room air saturation. Immunology workup was negative. Now see the CT scan.
Yeah. Over to you, Bhavin sir.
So you can see these images.
Yes, sir.
All right. A lot of discrepancy between all the history, etc. But let's start from the top. We've got centrilobular emphysema. It would be defined as moderate centrilobular emphysema. There's mild paraseptal emphysema. We do see these reticular opacities. As we keep going down, they keep increasing. It's like a mid-inspiratory scan. So the more inferior we go, we do see some reticular opacities. At no stage do we see honeycombing, maybe a little bit of traction bronchiectasis. So you've got some smoking related interstitial changes, and we've got the emphysema, etc. Now that's one part. Then we have this left lower lobe consolidation with air bronchograms. We've got a little bit of left pleural effusion. And then in the abdomen, we have ascites, we have these splenic lesions that seem to go from one surface to another, almost as if, the perisplenic stuff could represent hemorrhage. I don't know. Um, but there's a lot of stuff in the abdomen. There's some edema in the mesentery, especially around the spleen and the liver. So this is the sum total of all the findings.
What's the date of this scan, Bhavit?
18th of April. And that's the only scan we have.
There's one more scan.
But not with me. So
yeah, I can share that previous CT. I have not a proper video, but one mobile video is there that I can share in my PPT if it is madam is okay with that.
but there's no, yes, share it. But
That was done in 2023, huh, Rishi?
Yeah.
Yeah,
you
still.
could have just sent everything over, then we could have just put all of that together. Anyway, that's fine. Next time.
Just share it, Rishi. No issues. Make it fast.
Or, we could just move on to the question.
Yeah, and
come back.
yeah, sure, sir.
So what are Rushi's questions?
1 second, sir. I will share my screen again. Seen, now you can see that, right? Yeah, okay. So these were the investigations, Rushi. I don't think anything is relevant in that. I will move on. And CT chest, sir, has already shown, and CTPA. So I think when was this biopsy was taken, Rushi? That if you can say the time of taking biopsy.
It was in January last year, 2023.
Okay. Should I discuss Rajan sir and Talwar sir? Should I discuss this? Well, sir, slides now because it was done in the past. It is not.
You have a pathologist?
Yeah, we have. Yeah,
Let
well,
her
we have.
speak then. Let her speak what she wants to say.
Yeah,
Yeah.
yeah.
Yeah, okay. So good evening. So we have three sections here which are H&E stained. In the first one here, we can see that there is an emphysematous dilatation of the air spaces. The interstitium is showing mild chronic inflammation. And towards the lower end here, you can see, and to the left and lower end, you can see one vessel and the alveolar space surrounding that, which has got desquamated intraalveolar macrophages. So this is the features on the first slide. The second section here, we can see that now there is a diffuse intraalveolar accumulation of macrophages which have got abundant amount of eosinophilic cytoplasm, and this is a diffuse change which I can see throughout the parenchyma. There is interstitial inflammation, and the third slide here is showing the third one is showing again a distortion of alveolar architecture and a kind of bronchiole there. There is some pneumocyte type 2 pneumocyte hypoplasia, and there is mild chronic lymphocytic infiltration. So my diagnosis of this would be on these three sections alone would be a DIP like pattern, and I would with presence of some giant cell. Like in this section, they've shown one giant cell. So for me, on these three slides would be a DIP like pattern, and that being the major histological feature. So that's where I would go.
But
Yes.
most of the inflammation, madam, is away from where you are seeing the pigment.
So the main histological feature which I feel on these three sections is the diffuse intraalveolar accumulation of desquamated macrophages. That is the first thing which comes to me, and then the interstitial inflammation which comes to me is a secondary. I would have to see the entire slide, but to me this is it.
And even the fibrosis, what you are seeing is unlikely in DIP because DIP is not a fibrosing ILD.
Sir, I don't think there's fibrosis much in this. Sir. There is architectural distortion. The little pink bands which we are seeing is not dense fibrosis. It's actually the alveolar spaces which have got completely filled with the macrophages. I would like to put in an immunohistochemical stain for a macrophage marker, and I'm not seeing dense areas of fibrosis sir, here. To me, at least, on these three sections.
But fibrosis is there, ma'am.
Yes, sir, but it's not the dense
So it depends
fibrosis which.
what area they have sampled. That's okay. I agree. DIP is the very important thing, but pigment is very less in comparison to what you look at DIP. You don't see fibrosis. You are seeing giant cells. You are seeing extensive lymphocytoplasmic infiltrate. Only thing is there is no airway sampled in it. So it's very difficult to say that it is not HP. But I think the diagnosis given was HP in this case, which is like a competitor diagnosis there, I suppose. Asmita, it was diagnosed as HP
Yeah, yeah.
or exposure
Smita,
related.
what is the question still? We're still not
Yeah,
reached the
yeah,
question.
we will.
I
Harjit
think
Singh
because then we can come
Lumra.
back to this patho radio discussion. At least let's get to the question.
So the
Yeah,
question here is basically throughout this 1 year where he was in follow-up, roughly from December of 22 till we followed him up till August of 2023. Throughout this period, his lung function, physiology-wise, FVC remained stable. We have not been able to perform a DLCO because whenever he used to come for follow-up, he was breathless and hypoxic. So I have FVCs. One was done outside the clinic. That was in December 22. That was normal, 90% lung functions. The second was done in my clinic and that showed 86% or 84% FVC. And throughout, there was nothing suggestive of any abnormality on the lung function. And throughout this period, this patient had significant hypoxia. So his saturations varied between 78 to 85%. So initially, it was possibly thought maybe the HP is responsible for the hypoxia. But having treated it, even with normal lung function, I presume that maybe the emphysema was responsible for the normal lung function. So you would not see the deficit in the FVC, considering there was a lot of emphysema. But even after treating it, he continued to show worsening. So the second thought was maybe the pulmonary hypertension is out of proportion. So we put in a drug, but he worsened post vasodilator, which indicated the VQ matching might have gone down. So we had to withdraw tadalafil, and we continued him on steroids, and he recovered from that. Now, maybe the exacerbation at that time was COPD. It was not the ILD component, and his saturations came up. But still, the patient has continued to remain symptomatic, and we've got him after 8 months, around 2 weeks back, with a splenic infarct, which is the labeling given to us by our radiologist. We have not been able to find any bacteremia, vegetations to explain the splenic infarct. We have not been able to identify any hypercoagulable status or thrombus in the vessels to explain the infarct. Now, how does that splenic infarct fit into the picture right now in a background of ILD, which is sort of not that great? Even on the scan, the present scan, which Bhavin just showed, had left basal shadowing, which was not there in the previous scan. That scan was sort of a clear-cut ILD scan. This time there is a consolidation in the left base, but that could be just, atelectasis because of the splenic infarct and pain causing restriction of movement. So I'm still not convinced
Sorry,
about that.
Arjit, let me interrupt. Two, three things here because we're just going ahead. Have you aspirated the fluid in the peritoneum by any chance?
No, because this patient basically came to us with abdominal symptoms, and we picked up the splenic infarct, and we basically were trying to identify the cause of splenic infarct. Now, there is
We
some
don't know
volume
if that
overloaded.
fluid is fluid or blood, or we don't know any of that.
No, because the patient was in volume overload state. So patient was in right heart failure at this juncture. So we were not sure whether the fluid would be exudative. It could just be a partial part of volume overload.
And the left lower lobe is not just passive atelectasis. There's a definite bronchopneumonia slash consolidation in
So
the left lower lobe, possibly even in the right lung base. And just to kickstart one little part of the discussion where we constantly be saying HP, one of the things we have learned while there's no RCT to prove all of that is that HP and smoking doesn't, these two things don't really go hand in hand. So when Ritu says there's DIP, that explains the so-called HP-like pattern or whatever it is that may have been seen. So DIP makes sense in the setting of smoking along with emphysema, but HP just does not make any sense from a clinico-radiologic perspective. So that my two bits. Yeah.
the
Professor Wells,
DIP and
anything you would like to put?
the question still remains, why the disproportionate hypoxemia?
Sir?
Can I make a comment or two?
Yes, please, all ears. Yeah.
The reason you couldn't do a DLCO was because of breathlessness. Had you done that, I'm sure it would have been down at 20%.
Yes.
A number of patients, and CPFE is not a diagnosis under any circumstances, but the syndrome is such that when you have quite a lot of emphysema and quite a lot of ILD, you will get paradoxical normality of volumes, you will get hypoxia and pulmonary hypertension, reflecting the gas transfer. The thinking is that fibrosis pulls apart small airways, so you end up ventilating bully in that circumstance. You're ventilating dead lung, and your ventilation perfusion scans confirm that. So you will simulate pulmonary emboli on a VQ scan. So I see nothing paradoxical if you have a devastating reduction in DLCO, pulmonary hypertension, and hypoxia. If you've got the combination of a lot of emphysema and a lot of fibrosis, and I've seen those patients die with normal lung volumes. So I don't view what you're seeing necessarily as paradoxical. You've got secondary pH, which is why the vasodilator did not help a lot. And I agree, if you had disproportionate pH, there's logical to manage as for group 1 pH, but I don't see that. So my guess is that the pulmonary hypertension is highly appropriate to the severity and combination of emphysema and fibrosis. And we're being fooled, as we can be, by normal lung volumes. Regarding the ILD diagnosis, what have we got? We've got a CT snapshot and a biopsy snapshot. I hear DIP when I look at the biopsy. Bhavin will comment further, and we've only seen one scan, and I'm not sure that scan was at the same time as the biopsy. I can't say I was overwhelmed by evidence on CT of DIP. But DIP can fibrose most definitely. We have a number of cases, and there's a subset that most definitely fibrose towards an NSIP picture. HP, well, you've got some giant cells. I can't honestly say I saw anything else or heard anything else described, and maybe I missed something. But I can't say the biopsy otherwise seemed compelling. The dominant feature was DIP, which is not really an HP feature. Now, DIP can arise from non-smoking, and perhaps up to 50% of cases are in non-smokers. They can be driven by environmental triggers, for sure. So you may have an environmentally driven problem. I don't think it's possible to say. And on the scan, I'm just confused because on a snapshot scan, have you got bronchopneumonia at the time of the scan, which we must separate away from what is there elsewhere on the scan? You really need to get a sense, don't you, of what is robust on serial imaging. But so far, the bronchopneumonia bit, I don't think I can integrate into a diagnosis. So when I put this together, I think the hypoxia is likely to be appropriate with a dilated right ventricle and severe pH. That's a sort of pre-terminal pulmonary hypertension profile, isn't it? And I suspect the DLCO would be down at 20%. And the diagnosis is a little obscure. You might need to look at serial CTs. It may be there's a DIP driving fibrosis. It'd be nice to see a CT picture, though, that was more compellingly DIP-like. The consolidation raises the possibility, if it's really part of the ILD, that you've got a connective tissue disease pathway there. But let me stop because we may be able to look at serial CT images. At this
Do you
stage,
have Rushi?
I can't see HP
I'll
that
start.
robust as a diagnosis right now.
Yes, sir. Do we have images, Rushi?
Yeah, I'll share this screen.
Yeah.
This is on the June 2023, ma'am.
Yeah, just start scrolling. This is the time when the biopsy was taken?
No, the biopsy was in January.
Do we have January CT scan? Because Professor Wells wanted to know whether there was a pneumonia in there.
No, December scan we don't have. December first scan was done. We didn't do it in January.
Okay, fine.
No, so biopsy was Jan 24 or Jan 23?
Jan 23.
Just to say,
Months after.
I've seen quite a few HP cases in former smokers. So I wouldn't completely discount HP based on the smoking because I understand he stopped smoking 5 years ago, 5 years earlier.
Yeah, this scan looks more like HP.
It did to me.
It could just be acute exacerbation. No, I mean,
So
that is more likely a possibility than HP. I mean, and anyway, the biopsy doesn't really show that. So that not quite about.
The biopsy shows some giant cells, and not every HP biopsy is rock solid. I wouldn't discount, as I said, HP in a former smoker. So let's just look at the scan again and take it on merit.
Asmita, next time we should get all of these in advance. Huh?
Yes, sir. I thought he sent all the images. That's why.
I,
I'm
I
sorry.
didn't have
Yeah.
the PPT, so I wasn't aware there were
Yeah,
other.
yeah.
So we could have just done something to
Yeah.
get
I
it.
told him, yeah, fine,
So
sir.
that ground glass that we're seeing in June,
Mhm.
it's not appreciated on the current scan. It has kind of gone.
Yep.
And
Yeah.
fibrosis is more or less the same, and the emphysema is more or less the same. So if we're comparing it that way, whatever was the cause of that ground glass has regressed.
Yep.
But if you were looking at that scan, you forget about the smoking history. Um, HP would be a possibility, would it not, with that ground glass? I would be interested in what you felt about that.
I would just argue a little, the kind of a devil's advocate, that when you've got an ex-smoker who's got a smoking related fibrosis, whatever label you give it, with emphysema, if there is an acute clinical exacerbation or the patient has come with increased breathlessness, then any ground glass we would just assume, wouldn't we assume that to be more an acute exacerbation rather than giving a label of HP, etc.? Just a question. I mean,
Yeah, no, a fair question. But my take on the case is that our first scan was 5 years after the patient stopped smoking. So, having seen a number of HP cases that arise once somebody stops smoking, I'm not sure that the fibrosis has to be smoking related because there is this 5 year gap. The argument against is a biopsy showing the DIP element. So I think that we have to be honest and say that there are two possibilities here. That there is a DIP element, although maybe we don't have a very compelling CT picture, but it's a DIP element with fibrosis, or this is really a form of HP and all of the CT abnormalities have actually developed in the 5 years since the patient stopped smoking. And I don't know the answer to that, obviously.
Okay. I think.
So, any comments on the splenic infarct? Can we weave it into diagnosis? So, the CTD markers were negative this time and in the previous visits as well.
You need a CT angio. You have to look at the splenic arteries, the aorta, the renal arteries. There's a whole workup for splenic infarcts, Harjeet, that will need to be done to know whether there is a vascular component that has developed recently or not. And you have to aspirate the fluid to see whether it's blood or all of that, because otherwise you've no clue how that and what that infarct means.
No, what I meant was ILD of HP variety presenting with with an infarct. Are we sure that is an infarct on the spleen or it can be a differential of something else?
It's likely an infarct. If he had trauma, then that could
No,
even.
no trauma. So if the question was infarct plus ILD, any presentation which could sort of explain this? Is the infarct a part of the ILD process or it is something independent? That was the only issue.
My vote is for independent, but
Yeah, I also feel it's switch. Anyway, Rishi, if you can stop sharing, we can just take the consensus opinion and we can wind up this case. We are running short of time. Talwar sir, Rajan sir, anything else you want to add? Do you agree with HP or DIP? That is the like sir told, we have to go with the serial scans.
Yeah, I mean, DIP would not progress this fast after stopping smoking, right? I mean, as he got worse, I'm sure he quit smoking, right?
Yes.
Yeah, so it's very unusual, no? Harjeet, with steroids and cessation of smoking, the DIP would get this worse.
no, but it's not. No? So when you
Yeah,
look at the two scans, the fibrosis is stable,
correct.
emphysema is stable, and the ground glass of June 23 has regressed on the April 24 scan.
Fair enough. No, no, but in terms of his functional decline, his
That's fine. Okay, sorry.
But I don't think you can relate the functional decline to the ILD. He's got a
Yes.
dilated right
Yes.
ventricle with sky-high pulmonary pressures. He's got desperately severe pH.
Correct. The
So,
functional decline is all vascular. You're right. Absolutely. Absolutely.
right. So that means any statement you make about change in ILD is more about the scans. That's all we have.
Yeah.
You haven't got DLCO as a measure. The lung volumes are paradoxically normal. And so the only thing you've got for change in ILD are scans starting 5 years after he stopped smoking. So what you're finding on a biopsy might have been recent. I don't think that I can make an HP diagnosis that is compelling, but if I had to pick one diagnosis on the scan, it might have been that. But I can't do that. Sorry, somebody's interrupting me. Sorry, I'm online. I'm in Portugal, actually, so in a hotel room doing this, and the cleaners have wanted to come in. So look, the diagnosis is difficult. I don't believe that it's a CTD-ILD.
Okay.
If that OP element had been there as a longer term thing, and this was not infection, just bronchopneumonia, that would be different. But the whole constellation otherwise doesn't point me towards CTD-ILD. You can get a DIP reaction, which isn't DIP, and maybe that's what you've got. So you've got fibrosis, you've got ground glass that comes and goes. And I think if there was a genuine acute exacerbation with terminal pulmonary hypertension, the patient wouldn't have survived it in the way we think of lung injury. And lung injury is extensive as that, and I can't really see it that way. So I suspect that we might be dealing with immune dysregulation that isn't connective tissue disease. And I wouldn't care to try to tease out snapshots with DIP and CT snapshots with ground glass. So I'm going to call it unclassifiable disease, which we're allowed to call maybe 10 to 15% of cases. I'm going to say best management is to treat the immune dysregulation, whether it's DIP, whether it's HP, whether it's even a weird CTD, as best management of immune dysregulation. View the pH as secondary, and transplant felt like a good idea. Okay. If somebody would take a patient with such bad pH and a failed RV, but that's for a transplant physician to work out. Okay. Unclassifiable disease on what we've got. Does anyone want to say otherwise?
Talwar sir, anything from your side?
Yeah, my comment is regarding spleen infarcts, actually, what I think Harjeet is facing the problem. So I do not know, Harjeet, how much it would help, but under the circumstances, I would have evaluated the patient for APLA, look for portal vein this thrombosis, and also do a bubble echo to see if there is a reversal of the there's a shunt in the level, and it is trying to give more blood flow towards the other side. So I think these are the couple of things which we need to look into it, because it's very difficult. You are correct that ultimately you are trying to put in why the splenic infarcts in a patient who's an ILD. So how to fit that together rather than saying these two diseases are different. I think we need to look into a little more on the coagulation side. So I think I would recommend APLA and do a bubble echo.
Sure. I think we'll move on to the next case. Any comment from you, sir? Vimal Raj, sir, do you want to put anything?
No, I haven't seen the case in full, so...
Sure. I'll just share the screen for Rajan sir's case. We'll move.
Mithun, am I allowed to ask for Sujit's diagnosis of the ILD?
Oh, yeah. Sure. Meanwhile, I'll share the screen.
The second scan looked just HP, to me. I mean, we've seen so many HP scans like that, that it's sort of just like a photographic memory of HP on that scan, I thought. But, when you have biopsy and you have a patient declining like that, there are many things going on there besides HP.
I would have mirrored you on the scan. I'm just a bit concerned about a biopsy that shows a lot of DIP in 3 different sites, that's all.
Yeah.
Yeah, I think all yours, Rajan sir.
Yeah. Okay, so thanks. That was really a difficult case, Harjeet. This is hopefully a bit more straightforward, but I'm having a couple of questions here. It's a 57-year-old male. The whole case is summarized in this slide. Married, senior bureaucrat, lives in Mumbai, never smoker. He was noticed about a year and a half ago, January last year, to be breathless. His wife noticed that he was a little short of breath while talking. So they got a CT coronary done because he is a stressed not type A personality, but quite a stressed bureaucrat with a lot of work, less sleep. So CT coronary was done, which was okay, but an incidental ILD was detected. His dyspnea, however, has not affected his work or exercise. He runs and walks 1 hour every morning, even today. He does weight training. He struggled a bit when he went a few months ago to Machu Picchu, which is about 3,000 meters altitude. He struggles to sleep, and this has been a chronic issue because he's a workaholic. 5 hours, no autoimmune symptoms. His grandmother and one cousin have psoriasis, and there's no family history of ILD. He has fine basal inspiratory crackles. Rheumatoid factor CCP antibody ANCA is negative. You'll see the scans coming up shortly. ANA was 1 in 80, so we did an ANA blot because we wanted to. I felt young for IPF, so we got an ANA blot done. A myositis blot showed up a PI7, which was moderately positive, MI2, me2 positive. His vital capacity in October 2023, which was the first time he did it, showed a vital capacity of 3.36, which now in February 24 is actually up to 3.49. DLCO 73% predicted, KCO 98% predicted. His 6-minute walk distance, I haven't put down the values there. He walked over 500 meters, a 98% saturation going down to 95. And so maybe the CTs can come up and then I can put down my questions.
Bhavin sir.
So we have the supine images on the left, and we have the prone images on the right. We'll start from the base itself, just simpler to do that. Reticular opacity, subpleural basal predominance, traction bronchiectasis, and on the prone images, and maybe you could argue there's a little bit of honeycombing in the right lung base, and perhaps the little sliver on the left, but predominantly just traction bronchiectasis, reticular opacity, subpleural basal predominance. There is subtle non-dependent upper lobe involvement that we can see mainly on the right side, but it's there. And so we've got a fibrosing ILD, probable UIP, and arguably, therefore, fibrotic NSIP becomes a differential. And that's what we have.
Yeah. So this is where we are. And then there's my questions. If you can just put up that slide, because I think my question here is probable UIP, fibrotic NSIP. Should we do a bronch bal and a transbronchial cryobiopsy? His lung function was pretty good, as you saw. Surgical lung biopsy, start antifibrotics. He did meet Peter online at the Brompton, and I won't tell you what Peter said because Athol is online. Or should we just monitor, wait, and watch? These are my questions.
All yours, experts. Please go ahead. Professor Weiss. Yeah, please.
Okay, I would try to establish what this is. You said age 60, I think.
57.
57. He's got some autoimmune serology positive. He doesn't have...
Mild MI7. Can you put up that slide, Asmita, the first slide?
Yeah, MI7 and
Me2 is not anti-synthetase, and it generally goes with an absence of ILD or malignancy. I think the PL7 is perhaps more suggestive. And so you really are in two scenarios. The first is early IPF. The second is that he actually has a fibrotic NSIP. And I think at his age, with the limited extent, if you go to the paper in thorax where likelihood of UIP is computed, he wouldn't be crossing the traction bronchiectasis threshold of 4, and the likelihood of UIP is probably only about 50%. And you're adding in some connective tissue disease serology. So if it really is a myositis, it's unlikely to be UIP. So if you find UIP at cryobiopsy, that's likely to mean early IPF, and I'd use antifibrotic therapy. He's got more than an ILA because he has symptoms which led you to do the testing, and his DLCO was originally abnormal. All right, he managed to crawl back into the normal range. But probably if you'd measured his DLCO 5 years ago, he might well have been up at 100. So he's probably still well below his personal normal. The chances are, is what I'm saying. So I would establish what this is. I think you ought to be able to get a sample by cryobiopsy that does capture what you're seeing on the scan. I think if you really got stuck and the cryobiopsy was inconclusive, an algorithm might be to go to surgical biopsy, but I think you'll have a reasonably high yield. And UIP on a cryobiopsy is very strongly predictive of what you find on a surgical biopsy. So I'd start with the cryobiopsy. I wouldn't just monitor. I think that there's going to be a management which will either be for CTD-ILD with immune modulation, or it'll be for IPF with antifibrotic therapy. He's already experiencing some breathlessness. The one thing I personally wouldn't do at his age is just to monitor.
Okay. No, that's yeah. So I was thinking along those lines. In fact, Peter was keen to start antifibrotics if we ruled out connective tissue disease. And I just don't know how to rule out connective tissue. He has no symptoms at all. We haven't been able to do anything more here. And we have no high volume cryobiopsy centers in Mumbai. So I'm just wondering whether to send him elsewhere. Deepak, what would you do?
Or actually do a surgical biopsy. I mean, I think the trouble is once you've got that serology, I agree with you. How do you establish that it's not CTD? Now, I mean, probable UIP in the right setting is highly likely to indicate UIP. This isn't the right setting. By the way, was he a smoker?
Never smoker.
He's a non-smoker, aged 57, and he's got some autoimmune serology. So what we're calling probable UIP, and I'm afraid there's a sad tendency around the world, probable UIP is just UIP. And that's just rubbish. There's a recent Japanese series claiming that 2/3 of scleroderma lung is UIP because there's a lot of probable UIP in scleroderma lung, which is NSIP. Because NSIP is far more common than UIP in scleroderma lung. So in this setting, probable UIP leaves you toss of the coin, doesn't it? Could be fibrotic NSIP, could be IPF.
Yeah.
And the management differs.
Right.
The management will change, Sujit. So I think you should consider a biopsy in this patient, cryobiopsy, because if you get some CTD features to suggest that, because although I think our radiologist will not be happy with the diagnosis alone, but PL7 and PL12 are known to be associated with diseases which looks like a UIP pattern only, and like this it could be. And since it's a high profile case, missing it at this point of time might also not be acceptable. And most of the rheumatologists are very enthusiastic when this PL7 and PL12 come out to be positive, because they'll at the most repeat it from a different.
I have rheumatologist, sir. Do you
Do you have a rheumatologist on this call?
Yes, sir. Yes,
Now,
sir. We have.
Mithun,
Yes.
what do you do with these antibodies?
Uh, see, sir, this myositis profile, we do it by a Western blot technique. It's well known to cause very false positives, especially if it is 1 plus.
Okay.
Usually, myositis specific antibodies are said to be mutually exclusive. That means if one antibody is positive, other is usually negative. Like if Mi2 is positive, PL7 or 12 should be negative. If multiple antibodies come positive, we cannot take it as a positive or significant value. In this case, I can say that it's not significant. But if a patient fits into something, then it's a different scenario. But otherwise, we cannot take this test as significant. We
Okay.
cannot go by this test positivity, or we cannot call it as a positive myositis profile.
Okay.
So, Asmita, just a quick
Yeah.
comment. So, Sujit, the problem with biopsying this patient is that even if you pick up UIP on the biopsy, it still doesn't tell you whether it is primary UIP or secondary UIP. And you are still left with the dilemma of whether you would use anti-inflammatory versus anti-fibrotic. It has to be in the clinical context. So, if you basically clinically believe this is IPF, that UIP will be IPF. And if you believe this is too early an age and being a non-smoker, this is something secondary UIP, eventually you will have to consider anti-inflammatory. The second question was for Dr. Chankaria.
Can we
Yeah,
actually
I thought
deal with
sir doesn't agree with
the
you,
first
Harjit.
question
Yeah.
first?
Yeah.
Can I refer you to a perspective on UIP as a standalone entity, where across CTD HP, having a UIP pattern separates outcomes strikingly? I think the evidence that using immune suppression on a true UIP, and I'm not talking about studies where you take CTD with what we laughingly call probable UIP on CT in that setting, which half the time is NSIP, but true UIP, I don't think we have any evidence that anti-inflammatory treatment helps that. Now, I can understand that you might want to cover with gentle immunomodulation. So suppose you get UIP and you're not sure, but I would certainly be using the excuse to use antifibrotic therapy. And I suggest the TRAIL trial, limited though it was in rheumatoid lung, does support antifibrotic therapy if what you have is UIP.
Yeah.
So with respect, I think you could say that if you find UIP, you will use an antifibrotic. And then if you're concerned about secondary UIP with the CTD, you might add in a cautious immunomodulation, perhaps with mycophenolate. But to me, the driver of management is UIP or not.
No. What Harjit Singh sir wanted to point out was biopsy will not able to differentiate between primary and secondary UIP. That is what he wanted to say. Like
I
that.
understand, but if the biopsy shows UIP, you
Mhm.
have actually said it's UIP and not NSIP that's
Okay.
driving this.
Okay.
I just again,
Yes, Bhavin, just one question on that.
Yeah.
This thing about that FAPI, which you occasionally do for your patients, that fibroblast activating scan, will it tell us about something about
No, no,
inflammatory
no, no,
and
no, 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 no. We just did a few of those to see how FAPI
yes,
works
so
because there
would
was
it
a
help in this kind of a situation if
no,
there is
no, no,
so
no,
much
no. FAPI
going
is for
on?
inflammation. It's not. It's supposed to be a prognostic marker, not a diagnostic marker. And there is no good data on FAPI as yet to be used in ILD. We just tried out because there were a couple of those early papers, but we just need to wait another few years to figure out what to do with that. But here's my two bits, right? Just from a radiology perspective, and since we keep talking of homogeneity, heterogeneity, just a little bit of experience over the years. You've got this little cyst here. I mean, if he was a smoker, we would have said paraseptal emphysema. Let me mag this out here. But in the absence of smoking, this is honeycombing, a single layer honeycombing. It's heterogeneous. It's not homogeneous. You come down, even in the same segments, there is heterogeneity. So to me, from a radiologic perspective, while obviously you can't be 100% sure, if I have to put my hat in and give one diagnosis, I would say this is IPF. I mean, this is just what it looks like, which also means a biopsy is important because if this, prognostically, if this is IPF, this patient is in trouble irrespective. And therefore, if you can prove that it's a UIP, at least you have a plan to go with. I mean, that's my point. That for me, the pre-test probability of UIP IPF is far, far higher. It's not 50-50, it's more in the 80-20, at least from a radiologic perspective.
Sure, sir. Okay.
Yeah, I think I would factor in non-smoker, age, take your CT likelihood. I might downgrade it a bit just based on the clinical features, but still go with more likely than not that it's IPF by still some margin. I think we agree. There's enough uncertainty here. And the key management distinction is, can you find UIP? And if you find UIP, you then know essentially you're dealing with something that will progress in spite of management, and antifibrotic therapy will also cover a non-IPF UIP.
Yeah. Yes. Shall I start sharing the screen again for the third case? We are having 10 minutes.
Time your third case is complicated. It's
Oh
going
my God.
to take a long time.
No,
Okay,
we'll finish it faster. Let us
okay.
see. Okay.
So Vimal, if you're here, just see how this is going, because I was telling Asmita, if this interests you, then please do the next one. And
Yeah. So that we will like
then
once
maybe
we
we
are.
can do
Yeah.
alternate ones rather than every second Friday. So
Yeah. So this is the third case, and I will just quickly go through. That is landed up with me because she had history of lower respiratory tract infection, and my friend was treating because of LRTI. He did a CT scan. He found some cystic changes, and he thought it is LAM. And our center will be a better to treat. So when she came to me, she is a non-case of hypothyroid. She's 55-year-old lady, housewife, hypothyroid, presented with low-grade fever, cough for 3 weeks. She had evening rise of temperature, cough with expectoration and grade 1 dyspnea, but she was able to carry on. When asked, she said that she had history of polyarthralgia for 1 month. But in first visit, she was relatively all right. She came walking, and other than that, she was very anxious about her diagnosis. There was no other features. At an examination, ESR and CRP was high. But other blood investigations were normal. I'll just stop sharing my screen. Over to you, Bhavik sir. She had polyarthralgia. That was her only positive CTD finding, no other illness. I think one is, this is all old CTs or all, both the CTs are there, sir? Yeah, okay. So one is, the left one is April, the right one is January.
Bhavin, I think you're muted. We can't hear you.
thanks. Yeah. So the one on the right is the Jan 24. The one on the left is the April 24. You can see thin-walled cysts, varying sizes. They're not the same size, going from apex to base. Some of them are ovoid. Some of them are paramediastinal here as well. But you also have these opacities that seem to be peribronchovascular, pericystic, that extend from the hilum to the periphery. And we have a couple of nodules, but we don't have nodules within the cysts. If you come to the recent one, the cysts are the same. The opacities now are seen more as reticular opacities from the hilum to the periphery. Some of the ground glass or the denser lesions have partly regressed, but we still have an axial interstitial component that is along with these cysts. Very quickly, PLCH typically occurs in smokers. LAM is always a possibility, but the cysts are usually of the same size. PhD, which is not uncommon in India, can occur like this, but it is usually not associated with other lung lesions as we see here. LIP can fit, but typically you do need a defined underlying connective tissue disease, and this doesn't fit into amyloid or cystic metastatic disease or anything of that sort. So that's where we are. I'll leave you with that.
So, yeah, so the second visit when she came to me, she was in wheelchair. And that time was the one when I referred to my dear friend Mithun. And Mithun, if you can interpret this for me.
When I saw the patient had frank arthritis. Patient was not able to move. He had definite swelling of the joints. In my perspective, patient has an inflammatory polyarthritis. It was a lower limb predominant polyarthritis. There was when patient has arthritis and ILD, then we'll used to think in the line of a CTD associated lung disease or ILD, any lung disease. And because very unlikely that patient likely to have two different diseases. Therefore, in my aspect was to investigate further. I think I did the myositis profile. Myositis profile, ANA and ANA blot also. ANA blot came as negative. And myositis profile also only jaw1 was mild positive. It was not significant. And considering these factors, I will consider it as a CTD, may probably undifferentiated CTD. That was my diagnosis, and actually I started on steroids. Basically, that is for the joint part. Patient was not able to move at all. Very, very severe type of arthritis, and she actually had a very nice response to steroids, and almost completely became. He was able to walk within 1 or 2 weeks time. And considering the good response to steroids and the presence of arthritis, we just added a MMF or mycophenolate mofetil as a steroid sparing agent. With that, her symptoms, I think, had a good improvement with that. But if you see the antibodies, nothing very specific. But I will take this ANA2 plus homogeneous as a significant because although ANA blot is only jaw1 positivity, this homogeneous pattern is always significant. And on the ANA blot, we are checking only 15 antibodies. There are other antibodies which are not commercially available. Therefore, Na2 plus homogeneous, I feel that it should be taken as significant.
Yeah, thank you for that, Mithun. And as we can see, as Mithun said, not only the arthritis symptoms improved, other symptoms also improved, and she is clinically much better. The reason I have put the case here, the questions to the panel was, which Bhavin sir has partly answered was, is it LIP, LAM or IPEP? Because Jo1 came positive, we started thinking about this. Now VEGF has come like anything. Do we need to do it? It is 20,000 rupees in a outside center. It is not done in my hospital. Do I really need to do it? And there was few areas of fibrosis in the first CT which was done in January, which I also felt partially it's getting resolved. So was it COVID? Because that time the another diagnosis was suspected was viral pneumonia. So I leave that particular question and I will stop sharing my screen.
I'll move with the radiology part where, your last question. I think the patient had an organizing pneumonia-like pattern where the inflammatory component has improved, but we have probable residual fibrosis as like a fibrosing OP. So I don't think that's COVID related. That is one thing. And my only worry was that you do have these paramediastinal ovoid cysts. So more than VGFD, whether you need to do FLC and gene workup for which also costs about 25,000 anyway from a genomic lab. So
okay, thank you, Professor Wells.
Yeah, I buy the fact that LAM is difficult to sustain. I mean, not just on the imaging, but also the responsiveness to therapy. So I wouldn't go for VEGF. I hear the sense of excluding BHD as a separate disorder, but I do wonder whether the cystic change might relate to what has to be called a process driven by immune dysregulation. I'm kind of a bit wary of what we're calling IPAF. It's a research statement rather than diagnosis, but I think a multidisciplinary diagnosis of CTD-ILD is not inappropriate. It's just I'm a bit insecure about the exact lung process. Yes, elements of OP. You always wonder, once you know there's immune dysregulation in play, whether a vasculitis is driving either emphysematoid destruction or weird cystic change. The cases that have really puzzled me over the years have often turned out to be vasculitides that are not classical vasculitis. So I would just have that as a caveat. I'm not saying I know this is going on. I'm not sure what's going on with those cysts if they're part of the CTD. So I would say CTD-ILD anyway is appropriate. A working diagnosis, which is multidisciplinary. I wouldn't call it IPAF.
Okay.
Although I suppose you could go through and say it's ticking IPAF criteria, in that you've got the right morphology with the OP and you've got the clinical systemic picture. So officially, you're ticking IPAF criteria 2 out of 3 domains. Any other question there?
So you wouldn't give a label of LIP?
I'm hesitating. I mean, I'm saying I'm not sure about the cysts, Bhavin, and there may well have been LIP as part of the process. I think that's entirely possible. I'm just a bit wary of weird vasculitis, having been stung on occasions that either cystic change or emphysematoid destruction turns out to be part of a vasculitis. So I'd have those 2 scenarios, LIP driving the cysts, which I think maybe in the name of sanity might be slightly more likely. But a vasculitic process as part of the connective tissue disease is possible.
Yeah.
I wouldn't go to biopsying trying to chase that, though.
Yeah, I want to.
You've suppressed it anyway.
Yeah, I will not. Sorry. Yeah.
Does Vimal have any thoughts, Vimal, on the radiology?
I had a couple of things. I think GPA is one of the things which I was also thinking in terms of angitis, which is something can do similar. And as the case was going, I was doing some literature search. There have been few cases of SLEs also, which have been reported with similar patterns. So not sure if Mithun felt it was SLE based on the clinical and the immunology picture that they have got. Those were the 2 things I was thinking. But imaging LIP would have been my first, basically ground glass nodules with cysts. I'd have thought LIP, but putting everything else, GPA is something I'm really, I've also missed quite a few of GPAs. So that's something I would consider.
We didn't do ANCA, right? Mithun, we have to send, right? ANCA 1, C ANCA, P ANCA.
We have not done ANCAs.
We'll do.
I don't know. This type of lung picture can be seen in GPA.
Yeah.
It is there. We'll do.
Yeah, we will do it. We'll do it. Anything, Talwar sir, Dumra?
The lupus cases, were they vasculitic as well? So you've got GPA as a vasculitic pathway, lupus potentially looking at the literature, and then weird vasculitides in general. But I think I vote for LIP on balance.
Rajan sir, Talwar sir, Harjit, Dumra, anything?
So this scan is after treatment or before treatment? The 2nd April scan?
After treatment, after treatment. February we started treatment. April we did a follow-up scan.
So the lung functions improved, but the cysts pretty much remained where they were.
Yeah.
So the lung function improvement is from the areas which did not have the cysts.
Yes, hopefully.
So in that context, the cysts are in the background. The lung function improvement is subsequent to steroids and MMF. So obviously the cysts and the lungs parenchymal disease are not the same issue. I suppose the cysts have been there in the background. The parenchymal issue might have come recently with the polyarthralgia and the arthritis manifesting presently. So I would favor a dual pathology, a background lung disease with maybe a subsequent kind of a CTD presentation, which is incidental. they might not be related completely. So I would definitely look for a cystic lung disease in the background.
That's a good point of view.
Don't you think that if you're treating LIP, which has been around enough to cause cysts, and you also have active interstitial disease, that this is exactly what you'll see? That the treatment won't touch the cysts, but will blow away the bit that isn't cystic? I mean, I understand checking for PhD based on advice from Bhavin, for sure. It could be incidental. But I think this is also perfectly compatible with a single pathology underlying this, an immune dysregulation. You're not going to get resolution of cysts.
Yes, I understand that. I won't get the resolution, but the cysts are far too numerous for them to be not contributing to the lung function. So the lung function normalizing with those.
No, not normalizing. I think DLCO. Look, if you will see FVC
No,
alone
I'm
now.
talking about FVC, not the
DLCO was down at 51%.
Yeah,
It rose from 40
So
to
I understand
51.
that. But in no ILD, whether it is CTD or any other ILD, we see normalization of DLCO post-treatment. So I can take that with a pinch of salt. It's only that the cysts are far too numerous for them to be labeled as LIP in absence of any other residual damage, which can say that this was an ILD to begin with and is ending with it. In the sense, what I'm trying to say is the ILDs should have left behind some residual damage. The FVC normalization is too good for me to say that, this is...
So you know the FVC before she ever got disease, and you know that her personal FVC was not 120%.
Yes, I don't know that, but she's not symptomatic as well.
Yeah,
That doesn't bother me much, I have to say. But Bhavin, I think you're hearing this couldn't be LIP because there's too much cystic change. Do you agree with that?
No, I also think that sometimes these patients, so this may have been an acute exacerbation of something that's been there earlier. Let me just share this again. That, sometimes this is the first time that people present. I mean, even though there are so many cysts, it doesn't preclude the fact that it's a single diagnosis that we're making. And we all know that there are patients who have symptoms, but they, are compensating physically, so they never actually turn up until it becomes a little too much. So, and you do see them as perivascular cysts. I mean, this is so classic. You've got the vessel along the wall and all of that, and that's typically your LIP presentation as well. So I would go with a single diagnosis. In fact, there are septae as well. I didn't go into the morphology a lot, but look at this one. You've got this septae within the cyst. You've got perivascular cysts. And in fact, there's this new position paper, I think, through the British Thoracic Society on cystic lung disease, which even gives blown up pictures of cyst morphology to help differentiate one from the other. I think that fits in really well. So.
Okay. Yeah, I think...
I'm surprised. I thought this case would take like 45 minutes.
Yeah, I did good job with you all.
Shouldn't we hear from Sujit on his views on this case?
Yeah. No, the perivascular cysts, I think, I also think this is LIP, though I haven't seen too much. Is it common to get a lot of inflammatory polyarthropathy with LIP?
LIP usually in our disease mostly seen with Sjogren's, primary Sjogren's.
That's right.
We have seen patients with arthritis, but usually they present with initially arthritis and then we'll diagnose LIP. Here the reverse order. Patient had lung disease, then later on he developed. Therefore, we also consider the possibility of two diseases. Reactive arthritis also we have considered because patient initially didn't have any arthritis. Then later on when she presented, she had an acute onset of, initially she had polyarthralgia. Oh, that is for sure. But this, she was actually wheelchair bound after 1 month.
Yeah, I remember we considered Ritter's syndrome and all.
Reactive arthritis also we consider. Due to some infection, patient can get arthritis. That is also well possible. But if you want to take two disease as part of two symptoms as part of the same disease, then it's LIP with some undifferentiated connective tissue disorder.
If you're thinking of
And how
two
old is she?
possibilities clinically,
51?
why not then test for BHD? Because I think
Okay.
BHD is an underdiagnosed condition in our
Sure.
country.
I think
And
we
that
can
could
we can
be-
convince because the one thing which I didn't tell is she is the mother of a doctor.
Huh.
So he's actually asking me what happened to the discussion, and also I'll get back to him that he will be willing for those investigations.
Sure, perfect.
I think, yeah, just get BHD out of the way. And there's no family history of pneumothorax or
Never,
screening.
never, never, ever. This is first admission, and she was so anxious because the doctor gave the LAMP diagnosis and they landed directly here. And then I was like, okay, that time she was okay. Next time she came in wheelchair and now she's improving. So one more question is, should we just continue the same treatment because she's responding and we can meanwhile do the investigations?
Yes, yes.
Okay.
Yes. And I can get a cheaper VGFD done for you in Mumbai.
The treatment's
Just a
easier, isn't
question
it?
for the
Because she's
rheumatologist.
got such a good response to the initial therapy, and establishing whether she improves further with time, defining best lung function. Would you do anything but go on with what you're doing?
Yes, that's correct.
I mean, even if there really is a vasculitis, and I take aboard that that's unlikely, but I still just indicate that. I think, again, that management approach is appropriate. And if there really is a vasculitic element, maybe it will declare itself in time.
Yes.
But I think you don't have to chase that further.
Yes, sir. Talwar sir, if you are there, want to comment or we'll wind up.
There is an ICMR lab in Mumbai that can do the VGFD much more cheaper.
Sure, sir. We will get that. Okay, I think it was good, fruitful discussion. Thank you so much, everybody, and thank you, Vimal Raj sir. Thank you, Professor Wells. Thank you, Harjit Singh Dumra and Talwar sir, Rajan sir. Any comments? We will be just tech support. Can we just make it offline for us? Dinesh? Dinesh, are you there? Can you make it offline for us? Yeah. Thank you, all the delegates.